Hello everyone, I am Flavio Ribichini from Verona, Italy, and it's my pleasure to invite you to attend this new PCR webinar entitled Stent or Leave It, Considerations for a Successful DCB PCI. Well, this is exactly what we are going to do today. Stent or not to stent? That's the question. This is a webinar specifically conceived and prepared to address the difficult decision whether to leave a vessel as it looks after balloon or other thing preparation, or to stent it. So you will learn how to control dissections during lesion preparation, how to analyze different types of coronary dissections to decide whether to stent or not to stent, and we will see together some real-life cases with long-term follow-up to understand which is the result of this decision. Today, with me, it's a pleasure to have here in Paris Professor Bruno Scheller from Hamburg, Germany. Hello, Bruno.
Hello, Flavio.
It's a pleasure to have Joshua Numa from Galway, Ireland.
Hello, Flavio, and hello, everybody.
And to have Dr. Fahim Jafari from Singapore, who is connected from remote at the late time in the evening. Thank you for joining.
Hi, Flavio, and thank you for having me.
So this is made possible with a contribution by Medtronic. And before we start, I want to remind you that this is an interactive educational activity. So for those at home or at the hospital, you can write your questions, address your doubts and comments, and we will do our best to share your opinions and give you the best possible explanation to your questions. So with no further delay, I anticipate that this educational time will be divided in three parts. The first one is dedicated to the analysis of modern technology, intravascular imaging and coronary physiology on top of the good old angio to understand whether this might be of help in the decision to stent or not to stent. Who could be better than that? That Joshua? Please.
Yeah. Thank you for this kind introduction. So the topic of my talk is the assessment of dissections from angiography to intravascular imaging. So just to start with, the dissection is the disruption of the intima and or media by stretching of the arterial wall as described by Andreas Grunzig. You can see that on angiography or by means of the intravascular imaging. So dissection is a barotrauma. Without drug for the plain old balloon angioplasty, it can cause the constrictive remodeling or some proliferative neointimal hyperplasia. So that could cause a restenosis without presence of the drug. However, the drug-coated balloon has anti-proliferative drug, so that drug will prohibit those mechanisms and allow the lumen patent, and in some cases even allow the expansive remodeling. And most of the clinical trials use the angiography to classify and the dissection on angiography. So these are the typical NHLBI classification, which was also from the 80s. You can see that type A, type B, type C, type D, type E, type F. Type F is a total occlusion. Most of the clinical trials used type A and B as acceptable result, and type C, D, E were not really considered to not to stent. But in a recent trial, for example, in the cage-free 1 trial, which is a randomized control trial between the drug-eluting stent and drug-coated balloon in the de novo lesions, you could see in the DCB arm of those 1,000 patients in this cage-free 1 trial, if you stratify the patient with dissection, untreated dissection in the end of the procedure, and non-dissection patient without dissection, the clinical outcome was not different. Patient with a dissection has device-oriented composite endpoint of 6.1%, while the patient without dissection has 5.9% of the event rate at 2 years. And you can see in the right panel, depends on the type of the dissection, doesn't matter too much for the differentiation of clinical outcomes. So some time ago, we had a question about the OCT detected dissection. So how frequently can OCT detect the dissection? How to quantify it? And what is the relationship between the OCT detected dissection and angiographic or clinical outcomes? So these are one of the examples included in Transform-1 trial in the de novo lesion. We did DCB in the circumflex. Angiographically, there's a minimum dissection. But if you look at the OCT, you see a lot of dissections in the middle of the treated segment. You can really see more. Be careful in the cross sections. This is the thickness of the flap, and you can measure the aperture of the dissection flap and depth of the dissection and the width of the arc of the, this is the aperture, but also you can look at the arc of the dissection itself. And we did a meticulous analysis using some dedicated software to look at the dissections on OCT. So according to the OCT, in this case, total length of the dissection was 33 millimeter with the dissection volume of 13.8 cubic millimeters, and the section arc was 132 degrees. So it looks very dramatic on OCT. We saw sometimes the kind of the unidentified flying object on cross sections. So we did the 3D reconstruction, but most of the case this object was attached to the vessel wall in the longitudinally. You can see that in this 3D reconstruction, dissection is really the laceration of the intima and media, in this case, really extending throughout the vessel. It looks very worrisome on OCT. However, the patient did very well. This is a final angiography. We have a 6-month follow-up according to this study procedure. You see that MLD improved at 6 months from 1.42 to 1.52 millimeter. So despite all these dramatic imaging findings, the patient was doing well without any clinical event. So what we have found in this Transform-1 study was if you do that OCT during the DCB procedure, you will find the dissection in 95% of the cases. On angiography, it was detected only in 15% of the patients. The method of the OCT measurement of the dissection volume was very robust with a very reproducible measurement. There was some variation in the dissection volume according to the investigator sites, reflecting the behavior of the investigators. You could see that we look at the OCT detected dissection volume and the rate loss angiographically at 6 months. There was some correlation between the dissection volume and the rate loss. So if you look at this blue curve, which is for the paclitaxel coated balloon, if you have a more dissection, some cases has a minus rate loss, meaning that there's a rate gain in such cases. This relationship was less obvious in the sirolimus coated balloon, and there was some interaction for the p-value. So there might be also the interaction of the type of the drug coated balloon used during the procedure. The other studies also show that the predictor of the late lumen enlargement and layered plaque, and also the medial layer with the arc dissection with the arc of greater than 90 degrees is actually one of the predictor to have the late lumen enlargement at follow-up. This study also showed that actually the absence of the post-PCI medial dissection detected by OCT is the predictors of the target lesion failure. That means that actually the presence of the medial dissection on OCT is protective for the clinical event. Recently accepted DCB consensus also mentioned that no validated cutoff for the procedural success using intravascular imaging have yet been validated for drug-coated balloons. So as a summary, during DCB treatment, detection rate of the angiographic dissection is 15%, but if you do that OCT, the rate is 95%. So you will find the OCT detected dissection in almost all cases. Majority of the OCT detected dissection is clinically silent. There was some publication suggesting that actually the dissection detected OCT has related to the favorable outcome. So OCT and IVAS can help to improve the vessel preparation by precise sizing, length measurement, but are not indicated to make the clinical decision whether to stent or not. Thank you for your attention.
Great, Joshi. Thank you very much. Nice image, nice examples to see the discrepancy in between an angio, which looks almost normal, and an OCT, which looks terrible.
Yes.
Another important concept is that this terrible looking, that means that the media of the vessel has been disrupted, helps the drug to get in and improves the long-term results. So this is an aim in our treatment with DCB. So my question goes to Bruno to anticipate a little bit what he will explain us to prevent these nasty dissections. So except the vessel occlusion, I mean, does it mean that any kind of the old classification that we have to forget, I suppose, of the dissections deserve an attempt? I mean, we can still try to live without stent despite this class C, D, E, and so on.
Yeah, Flavio, I think this is very important that this old classification is not guilty anymore. We will learn later on in this webinar that flow is one very important factor, and the true lumen is the other important factor we have to observe. And third, of course, the risk that existing dissection deteriorates. That's the fear.
Okay. So it's flow through lumen, so we'd rather don't see these awful dissections with OCT.
Yeah.
Is that right? Maybe IVL, intravascular imaging, is very useful to perform a good lesion preparation.
Yeah, I think that's key, because we have learned that we have to accept dissections, that dissections are good, but we have to find the point where we should not create too much injury, and that's very important.
Okay. We look forward to hearing your advices on that. And now we move to the next additional technology that might help to understand better the angiographic result after lesion preparation. So, Fahim, tell us about the use of physiology in this setting.
Thank you, Flavio. So my job over the next couple of minutes is to talk about the role of physiology in assessing dissections. And that's an important question, given what Dr. Onuma just showed, the complexities and the conundrums that are involved in assessing dissections anatomically. And so the question you have to ask is that, is physiologically guided balloon angioplasty new? It really isn't. Back in the day, Andreas Grunzig was a physiologist at heart and showed very, very early that if you do balloon angioplasty and you get a dissection and you have a low translesional gradient, you actually get very good restenosis rates. And so the concept is not new. The fact of the matter is that balloon angioplasty and dissections go hand in hand. The mechanism, as Yoshi just pointed out, of balloon angioplasty working is dissection. And so if you keep that in mind, then the question you have to ask is that, can physiology help pick up the good dissections that you can leave from the bad ones? And that sort of ties in with the question that, does it even make sense? Why do physiology? Does it make biological sense? And if you think about it, it actually does, because when you sort of narrow everything down to the sort of fundamental principles, lumen is actually king. Whether it's a stent or it's a balloon angioplasty, the lumen you get is king. The problem is that dissections often produce haziness on the angiogram, and assessing that haziness is very difficult when you have balloon angioplasty-induced dissections, because as you can see on the right side, whenever you have balloon angioplasty and you have dissections, the lumen is irregular, and so it is very hard to assess that lumen either on the angiogram and even more so on intracoronary imaging, as Yoshi pointed out, using OCT or IVUS. So the question then comes is that perhaps, maybe, flow or measuring flow could be a surrogate of a good lumen or a good cumulative lumen. In other words, does good flow equal good lumen? Well, this sort of was looked at very early in the angioplasty experience in the 90s, where they showed that if after balloon angioplasty you get an FFR of more than 0.9, so in other words, excellent flow, the outcomes both in the immediate phase as well as long-term over a period of 2 years are actually excellent. So getting good FFR after balloon angioplasty in the POBA era translates to good outcomes. Now, the question is that, does that apply to DCB or POBA with DCB? And in that sense, the other question that comes is that, do you really have to achieve an FFR of 0.9? And can you get away with something that's a bit lower? Because as you heard earlier, when you do DCB, you get positive remodeling and you don't get the restenosis you get with just plain old balloon angioplasty. And Professor Shin and colleagues from Korea looked at this, where they looked at 66 patients who underwent balloon angioplasty, and then they did something interesting. They did FFR, and if the FFR was more than 0.85, they chose a lower cutoff, They just treated it with DCB. And if the FFR was less than 0.85, in other words, not great, then they ended up putting in a stent. And they looked at the angiograms at 9 months. And it turned out that if you got a good FFR and then you did DCB, at 9 months, angiographic patency was maintained. Now, I must point out that this was not a randomized trial. It's observational data. And the authors in the paper made no comments on dissections, but through personal communication, I was told that any dissection that was type C and below, they would leave it if the FFR was good. So a pretty decent dissection they would leave as long as the flow was good. And the same group also looked at using IFR, and at a cut point of 0.86 showed similar outcomes, which is at 9 months, significant reduction in late lumen loss in the DCB group with good clinical outcomes comparison to stent. Again, non-randomized data and no comments made on dissections. And another group relatively recently looked at using angio-based FFR, in other words, QFR, instead of a wire-based technology, and looked at about 280 odd patients who were then stratified according to what the post-DCB QFR achieved was. And as you can see on the right-hand panel, if you got a good QFR post-DCB defined in this study as more than 0.86, it was highly predictive or good outcomes. Again, the limitations of the data is it's not randomized, and they didn't specifically look at dissections. Now, with that in mind, what do the consensus documents say? Well, here's the European consensus documents, which suggest using a cut point of 0.8 post-DCB as a cut point for good flow, and you can leave things. The Asia-Pacific guidelines consensus group used a cut point of 0.75, so a slightly lower cut point, with the understanding that conceptually you could leave things even if you got a less than perfect FFR, because the vessel is likely to remodel positively and favorably in the future. And the Japanese consensus group also recommended 0.8. Now, with that in mind, let's look at a quick case, a 53-year-old man, non-STEMI. And this is what the angiogram looked like. You can see that there is a critical proximal LED lesion, but there's also considerable diffuse disease distally. What we did, we went ahead and put in a stent in the proximal LAD with an excellent result on IVUS. I'm not going to sort of bore you with those details. And I actually pulled the wires out. But then when I looked at the angiogram, I was just not happy with the distal LAD. So what did I do? I did physiology. And you can see on the left-hand panel, the FFR was significantly abnormal. And on the right-hand panel, the IFR was abnormal, with most of the pressure losses occurring in the distal LAD. So from a technical standpoint, what did I do? I left the pressure wire in place, went ahead and dilated the LED using a Scoreflex balloon, and then after getting a good result, went ahead and treated it with a 2530 Prevail drug-coated balloon. And post DCB to the distal vessel, it looked very good. You can see perhaps during that there is a small dissection in the mid vessel where we did some balloon angioplasty. I don't know if it's showing through the screen. And we did post balloon angioplasty FFR, and the FFR improved from 0.73 to 0.84. And on the right side, the IFR improved from 0.83 to 0.91. And this patient, over a 1.5-year follow-up, has done amazingly well, is running races and marathons, is completely asymptomatic. So what does all this mean? Let's put it all together. What I would say is that the preliminary evidence, not randomized trials, but preliminary evidence suggests that if you get a good POBA result, defined as less than 30 to 40% residual, and you get a good physiological result, and you can define that as more than 0.8 or more than 0.75, or an IFR more than 0.86 using wire-based technology, or a QFR of more than 0.86 using wireless technology, you can potentially leave the stent behind and just do DCB. It is potentially a reasonably good strategy, at least based on the current evidence. I think it's also important to be circumspect and realistic about the data, because there are some caveats. The first caveat is that we don't know what the exact threshold is acceptable. As I pointed out, 0.8, but then other groups have shown 0.75 is good enough. What is the acceptable threshold to leave? What is the residual FFR you are comfortable leaving behind? And of course, it's important to appreciate that the evidence is observational, not randomized, and we do need to see randomized trials using physiology as a guidance mode for a DCB angioplasty. And then the interplay between dissection grade and IFR or FFR still is unclear, in the sense that can every type C or maybe even a type D dissection be left as long as the physiology is okay? That question is still unknown. Ladies and gentlemen, thank you very much.
Wow. Thank you, Fahim. That was very nice. I mean, your concept is that, as we have been doing for many years, we are translating the measuring of pressure into a surrogate of flow. And you assume that if the flow is good, the result will be safe and at the long term will be good, because we are adding to the mechanistics of the balloon dilatation the drug effect to prevent recoil and neointimal hyperplasia. So my question to you, because we know that in your region there is a lot of diffuse disease and small vessels, so DCB, it's a very appealing technique. Do you regularly use a pressure wire to do this diffuse disease, or you prefer to use non-wire-based physiology with angio-based softwares?
I think more recently we've been doing more of the QFR or angio-based physiological assessment. I will also admit that we don't do it as regularly as perhaps we should, but at least the initial evidence is suggesting that that is a reasonably good strategy. And you're absolutely right. In our part of the world, we see a lot of diabetes with a lot of distal vessel diffuse disease, and so the concept is fairly appropriate and valid for our part of the world, and I think most parts of the world, actually.
Okay, and then the other point, which is very interesting, is that more or less the cutoff points that you have shown, although you have clearly stated that there is no randomized trial to identify this cutoff point, are more or less the same we are used to work with when we treat lesions with stenting or when we make the diagnosis of ischemia-inducing lesions. So we stay on what is known, nothing new.
Pretty much. I mean, as I said, Professor Shin and colleagues looked at 0.8, and then they did another study looking at 0.75 and got similar results. So probably, I think the bottom line is you don't need a perfect FFR post DCB. A reasonably good FFR, 0.75 being a good cut point, is probably okay to allow you to leave the stent behind and just treat with DCB.
Okay, we are receiving a lot of questions from everywhere. From Kenya, our friend from Kenya is never missing one appointment. From Qatar, from Uzbekistan. I'll try to focus one important question to you, Joshua. A colleague said, if more dissections, better results, does it mean that we should be more aggressive than what we have been so far when we avoid the stents?
I think, as Bruno mentioned, one of the important points is the flow. I think as long as flow is maintained, you can achieve more dissections, but there is a balance between the too much dissection causing the no flow or the flow impairment. But you have to keep the flow good and achieve as much dissection as possible.
And Bruno will tell us his secrets to reach this goal. And another short question. Antithrombotic therapy. Does it make sense to use something different, more aggressive compared to what we use conventionally, dual antiplatelet therapy and some unfractioned heparin?
Acutely, probably not. I think you can use it as normal heparin, etc. For the long-term antiplatelet therapy, there's one randomized trial which was conducted in China to look at the 1 month and 6 months DAPT, but in acute coronary syndrome, and that cage-free 2 didn't show any difference between the short and long.
So for the procedure, we use standard antithrombotic therapy. Yes. Then one of the advantages of this technology is that we can reduce dual antiplatelet therapy, which is very appealing for patients being high risk of bleeding. Okay, then Bruno, we have been looking forward to hearing from you, from your experience, how and if is it possible to control bad dissections to leave a safe and good-looking result without the stent.
Yeah, great, thank you, Flavio. The first thing is we have to look at the possible mechanisms of angioplasty. And in the early days, for example, Martin Kaltenbach said, we're creating some kind of footprint in the snow. Unfortunately, this is not the case in reality. And you can reach this footprint, if at all, with stenting, but not with angioplasty, because the mechanism of angioplasty, unfortunately, is some kind of borrowed trauma we create, and we have to deal with dissections. Our goal with lesion preparation should be to come a little bit closer to this footprint in the snow, but finally to accept dissections. And one of the lessons that has been learned in the early days of angioplasty was that with POBA, if you are more aggressive, you have to pay a price for it because the trauma is much more, and this creates more healing of the artery, and this led to the old axiom that the more you gain, the more you lose. So there was limited possibilities to improve your outcomes with improved lesion preparation. This has changed now with DCB. Yoshi already showed you the data on the right from the Transform 1 trial showing that a higher dissection volume is associated with lower late lumen loss. And this is really new and very amazing. And one of the other things we had to learn in the past, this is data from Bernardo Cortez's group, is that most of the dissections heal within a normal time frame, so you have not to be afraid that dissections increase, but at the end of the day they heal. One of the questions we hear always from criticisms is that it's not safe not to stent an artery because we have a high risk of acute and subacute vessel closure. We looked in the angiographic sub-study of the Basket Small 2 trial at the outcome at control angiography, and none of the DCB-treated lesions was occluded. But we had a relevant number of occluded stents, and this clearly supports the safety of this DCB-only approach if you follow the rules of lesion preparation. And one of the most fascinating things in DCB treatment is late lumen enlargement. So you do not need the perfect initial result. You see over time an improvement in the lumen. You can see this on this example on the right. A small lady with a LAD lesion, 2.0 millimeter in diameter, treated with DCB. The final result was not really good, but look at 15 months later, the artery has grown and looks like a healthy vessel. And this leads us now to this new axiom in angioplasty-based treatment. It's not anymore the more you gain, the more you lose. Now, if we do adequate sizing, if we have controlled dissections, we can further reduce late lumen loss, and the more you gain, the more you get. And that's really new for this therapy. This is an example how to deal with dissections. A 60-year-old male, diabetic, and he has this long diffuse disease in the mid-LAD, 2 main lesions. And I started with semi-compliant balloons, 2.5 pre-dilatation, and what you can see on the right is not a good result. We have a very long dissection with contrast medium outside the lumen, and we have almost no lumen gain in the distal part of the treated area, so this does not fulfill the criteria of DCB only. So years ago, I would have decided to go with stents, 5-6 centimeter stenting in this LAD, which is okay acutely, but not a good idea for the long term. But we learned a lot about lesion preparation meanwhile, and this is again a paper from Professor Shin's group from Korea, and they looked at the impact of specialty balloons, in this case scoring balloons, for lesion preparation. And what you can see is that the frequency of type Z dissections goes down, the residual stenosis improves if you use scoring balloons instead of conventional balloons. So that's one of the lessons. We have to go further beyond semi-compliant balloons. And the second lesson is, this was also known from the old angioplasty times, but it has been confirmed now for DCB treatment, that longer balloon inflations improve your initial lumen gain and allow for control of dissections. And this paper recently published shows up to 2 years an improvement of outcome if you use long balloon inflation times. In this case, it was 180 seconds. And so we can optimize what we are doing. And coming back to this 60-year-old male, on the left you can see again the result after pre-dilatation with semi-compliant balloons. And here I used a scoring balloon 2.5 with multiple and long inflations. And on the right you can see that the dissection is much better controlled and the lumen in the distal part has improved significantly. And this result now fulfills the criteria of DCB only for a successful lesion preparation. And I ended up with 2.5, 2.5 and 3.0 paclitaxel-coated balloons in this area. And you can see that with this longer balloon inflations with the DCB, the result has even more improved, and this almost looks like a stenting. And if you compare us with the initial result, then you can see that we really can improve the results of our lesion preparation. And that's my conclusion. We have to accept that dissections are the mechanism of angioplasty. They are not the enemy of angioplasty. Medial dissections improve the drug transfer to the vessel wall. Our goal should be a one-to-one sizing, not more, but one-to-one sizing. We can attach dissections through long balloon inflations, and we need additional tools for lesion preparation, including specialty balloons. And this allows, in many cases, the conversion of non-benign into benign dissections. And if we go beyond those lesion types, going to calcified lesion, of course, we need much more calcium modification techniques. And if you go for ACS patients, you have to get rid of the thrombus before you use the DCB. Thank you.
I am sure that we have plenty of questions because these are very practical issues. I remind you that this webinar is not based on science. There is no science behind the management of dissection. It's based on experience. And this is why I'm happy to have you here. I have some questions and others are coming. So 1-to-1 ratio, you have a dissection. Scoring balloon makes a difference.
Yes, scoring balloon makes a difference. 1-to-1 means not by eyeballing. 1-to-1 means by QCA, and then you can add up to 0.4 millimeter in diameter, okay. Or you can use intravascular imaging to define the real diameter of the artery.
When you talk about scoring balloon, are you including also cutting balloon?
I'm also including, we have no data comparing those two types, so it's an open question, and it makes, the practical question is with what device are you more used to work with it, and I think that's the selection criterion.
And have you made an idea on why that happens? I mean, you have this dissection, looks bad, you put a normal or non-compliant balloon, you don't fix it. You put a scoring balloon and your case was amazing. I mean, it's a stent-like result.
So you have, with those specialty balloons, you have much more controlled force to the whole length of your treated area. And I think it's very important to have homogeneous forces to the wall, to have homogeneous expansion, and maybe create your own dissections that are clearly controlled and longitudinal.
Okay. Any experience with intravascular lithotripsy as a special balloon?
Yes, that's very, very interesting, and there are new data coming up. If you do IVL, you create channels for the drug to get in the vessel wall. You make the wall softer, and this is the ideal case for DCB.
Good. Good. The other point you made very clearly is long balloon inflations. I have a certain age, and that was the base of PCI before stenting. And I have to admit that I started doing PCI at the time stents were not on the shelf. How long would you try? You said 180 seconds, that's 2 minutes.
Yeah, I do not do 2 minutes, but I try to inflate longer.
Longer than 2 minutes?
No, longer than usual. No, I mean, we are used to inflate the balloon shortly, to prepare it for the stent, and then put the stent in.
If you do 2 minutes, you deflate, you inject, and you have still the dissection.
I'm
Is it worse to do it longer or not?
No. I don't think so. But I think if you do several times 20 or 30 seconds, is also a good idea. So you don't have to do this 2 minutes. They did it in this trial, but in reality we do it short.
Okay. Joshi, a colleague asked a question. It's quite simple. He said, I have opened my intravascular imaging to define the vessel characteristics. We said this is useful for a good vessel preparation. How can I refrain to use it to observe the final result?
That's a very good question, but I think you can use the intravascular imaging for the device selection and size of the device and good preparation of the lesions, but I think you have to be prepared. If you use that OCT or IVUS after the DCB, you will almost all cases see the dissection, just to prepare not to react too much on the intravascular imaging.
So you can use your intravascular image you see, but this should not push you to overstent. I mean, you have to trust what we have been saying. Physiology, flow, clinic, ACG, and of course, good luck. Another good question coming from Argentina. Is there an algorithm to guide this sequence of devices that you have mentioned, Bruno, to avoid nasty dissections?
It would be good if we would have it, but we do not have it yet. So at the moment, it's mostly experience of the initial operators. But starting with semi-compliant semi-compliant balloons makes sense to get a feeling how the lesion reacts. But at the end of the day, you will end up with better results with non-compliant balloons and with specialty balloons. So I would say this is the usual sequence you are doing. And if you are going to calcified lesions, of course, you have to think about rota and IVL.
Mm-hmm. Fahim, are you still there? Can you hear me?
I am, yes.
Yes. Listen, this is a very interesting question. A colleague asked, I mean, dissections are becoming very popular. We used to consider it very nasty. Now we like it because it facilitates the penetration of the drug. So the question is, if we don't see a dissection on fluoro, is it still a good idea to go with DCB?
Oh, I think it is because, as Yoshi pointed out, many of the times you don't see a dissection on the angiogram, but those dissections will be there on OCT if you have achieved good luminal gain. So if you don't see a dissection, but your luminal gain is good, then go for it and use DCB. I think you'll be okay.
Yeah, that's very clear. I mean, you don't need to see it. You know it is there each time, provided that the residual stenosis is less than 20%. This is a baseline decision before using any kind. I mean, even before stenting, you should remove all residual stenosis. So this is a very, very practical advice. Good. Which is the threshold, Bruno, to give up? Say you have done your sequence of dedicated devices, you have gone low pressure, long balloon inflations, you have done your cutting or scoring, and in the end, a colleague says, okay, we're talking about a proximal LAD with a bifurcation that it's going to the diagonal. When you decide to go with the stent?
So it's very simple. It depends how experienced you are. If you are not that much experience with DCB-only treatment, you will decide in the very early stage of your lesion preparation to cross over to stenting. The longer you are doing this, the more you accept. And I would, of course, go for stenting if I still have severe dissections in the proximal part of the big arteries. That's for sure. But if you go in the more distal and long diffuse disease, I'm willing to accept much more dissection. And at the end of the day, it's flow. Even if there is a big dissection type C or D, and the flow is good in the distal part of a small artery, I believe it.
Okay. So we are basically driving our decisions on all concepts: angio, flow, chest pain, ACG, and not specifically on what we see, because having a look at OCT is very detailed. Any place, Joshi, to use IVUS instead of OCT as intravascular image? And so the definition is far less ideal. We see less, but is there a role to use IVUS instead of OCT?
There was a trial showing that the IVUS guidance is achieved a better result compared to the angiographic guidance. But I think in general, if you use the IVUS, detection rate is the probably quarter of the OCT, the rate observed on the OCT. So, for example, when we did the OCT after stenting, each dissection rate of that study was 80%, but on the IVAS it was only 20%. So I think you will see less dissection by IVAS. But for example, in a vessel, very large vessel, maybe there's a time to time the IVAS is a better option compared to the OCT.
Okay. I'm getting worried about all the questions that are arriving. We will not have the time to answering, but I have just picked one of them. Bruno, is it using a body wire and a balloon something equivalent to a scoring balloon as it used to be before scoring were invented?
I think it's okay to do, but it does not replace it.
It's not the same.
No.
Another question, any role for 2B3A inhibitors to reduce the risk of thrombosis after the dissection?
I don't think so. I think we are fine with current dual antiplatelet therapy. The question is how long do we need it? Some people say at least 2 weeks because we have microthrombus in the dissections until they start healing, but that's an open question.
Very practical question to you, Fahim. Do you keep the patients longer in the hospital after a DCB with a dissection rather than with a stent?
No, I don't think so. I think if you've got good flow and you've got a good result, then you've got a good result.
Okay, I'm happy to address all these questions, but we have to move. And the third part of this webinar is dedicated to the assessment of dissections. It's the decision to stent or to leave, addressing real-life cases. So we go, please, to the next slide, and we see real-life examples on how to manage cases with dissections. So the first one is a case we did 3 years ago. It's a 66-year-old female that had who underwent previous cardiac surgery. You see, she has a nice mammary artery, which is going to the diagonal actually, and the diagonal is saying flow retrogradely to the LAD, and the LAD has a very tight lesion in a significant bend. It's a very tortuous vessel, and the graft to the right coronary artery and the oblique marginal are occluded. A short time after this operation, I had to put a stent on the left main of the lady because she had chest pain, and she did well for 2 years, but then this lesion in the mid-LAD came and brought her back again to Verona. You see that there is no doubt, the physiology is significantly impaired with a QFR 0.52, and of course this is the kind of lesions where I would like to avoid implanting stent. First, it is not for granted that you will drive a stent up to there because of the tortuosities. Then the stent will be really very, very in a bend, which creates fracture of the metal. And then you have the origin of the diagonal, which I wouldn't like to occlude because all the flow coming from the mammary to the LAD is coming from this diagonal, which has a significant stenosis at the ostium, and all this system is providing collateral circulation to the right. So it's really very high risk PCI, and it was really very difficult. You see, it was impossible to drive a balloon. It's a 1.5 on a pilot 50, it did not cross. I need to put an extension, not an extension, a microcatheter, an extra support wire, and push a 1.1 balloon to start the dilatation. Then, following Bruno's advice, I went very carefully with a 2.0, a 2.5, and up to a 3.0 non-compliant balloon for lesion preparation. And to my surprise, a good new paclitaxel drug-coating balloon navigate easily through the lesion. So the drug release is performed, but then you have this dissection. And then, of course, the question is, would you stent or leave? You see the image. I will go with Yoshu. Would you leave that, remove the wire, or put a stent?
I will leave it because the flow is good. My only concern is a bit of the recoil of the lesion because of the calcification. If we are sure that it is expand well, probably we can leave it alone.
Bruno?
Of course, I will leave it. As Yoshi said, we have a good flow, and what's important too is that the true lumen at both places is bigger than the false lumen, and good flow and bigger true lumen, these are the criteria where I can leave it.
This is what Antonio Colombo used to say. I do IVUS because if the IVUS catheter is in a bigger lumen than in the false lumen, I will leave it. And indeed, this is what I did. You see, this is the final result. Of course, we kept the patient at least 10 minutes on the table to make sure that there was nothing abrupt. But she did well. This is the physiology, which is very, very rewarding. I mean, it's 0.96, totally normal, and the lady has a 3 years follow-up uneventfully. She doesn't want to come back to do angiography because she has been many times in the lab, in surgery and all that, but it's a clear demonstration of an apparently nasty dissection that behaved very, very nicely. Of course, there are some cases where you need your stent, and here, Bruno, I would like to know your comments on this. It's a case performed in Verona. It's a young male with these small vessels with long lesions, so ideal anatomy for a drug coating balloon. You see, we start with a preparation with a 2.5 semi-compliant balloon in the first diagonal, and then it's a 2.5 paclitaxel coated DCB, and it looks great. Actually, the first diagonal looks great, almost no apparent dissection. In angiography, of course, we know that if we go with OCT, we will see it looks awful, but we don't do that. Same approach, same balloon on the second diagonal, 2.5 drug coating balloon, another drug coating balloon. We never use twice the same because the drug is gone. And again, very lucky result, very happy. So we take courage and we address the distal LAD. But this time, I think, I don't know, probably we ran out of the 2.5 drug coating balloons and we used a 3.0. And guess what? There is a subocclusive dissection. You see it's a 99% residual stenosis. So we go to the step forward. We do prolonged inflations, 2 minutes. But in another incident, you see it's getting worse. It's totally occlusive, and so at that point, there is nothing wrong using the good old friend we all have on the shelf. We put a stent, but the stent, indeed, it's a small one. I mean, the stent we use is a 225, which is an acknowledgement of probably the mistake we did using a 3.0 balloon. What do you think, Bruno?
Yeah, I mean, you gave the answer. We can be aggressive in our sizing, but we should not size more than 1:1, and I think that's a very good example that you can challenge the anatomy, but not too much.
Yeah, and at that time I didn't learn from you that we could have tried using scoring balloons. Actually, I have to say we are not fond on scoring balloons, but after what you have explained, I think I will start using them because it was a step that we missed on that. Of course, we put the stent, everything was okay. We have another case. We have one more case. I anticipate it's a very provocative case. It is not intended to avoid the use of stenting. Is to be very sincere and going together through a case that could have been done better. And this is, the spirit of sharing. This is sharing experiences. There is, as I said, no science behind this. There is no randomized comparison, leaving dissection or stenting. So here we go. It's a 70-year-old male with acute MI. He's assisted by the emergency system, and he has fibrillation during the admission in the emergency room. You see there is an acute MI, anterior MI. It's in the night. And one of my young colleagues performs the case, and you see it's a total occlusion of the proximal LAD. It's a thrombotic proximal occlusion. And so the first thing to do is opening the vessel. It's a 2.5 semi-compliant balloon with flow recovered. So chest pain reduces, there is good flow. The guy has been my fellow, so he has been trained in trying to avoid metal, and this is a 3.5 20 millimeters paclitaxel eluting balloon. And this is the result. So the question to you, and I will start with Fahim, who is far away but has seen the case, would you stent or leave it?
With that extensive dissection, I would watch very carefully. My immediate inclination would be to stent it, given what it looks like. But I'm sure you're going to tell us something else.
Bruno, would you do the same?
So for me, it's fine, despite the fact that this proximal LLD, because this thrombus has gone away in this situation. We have a very good lumen, and the dissection looks benign. So I would go further with DCB in this.
Yoshu, you are the youngest. Would you trust this image, or would you try to do something different? I give you another element. The ACG is normalized. The patient has no chest pain. Oh. And it's almost 2 in the night, which makes no difference, but it's a detail.
Yes, yeah, I think flow is good, and yeah, if the clinical symptom resolves and ECG get normal, probably I try to leave it alone.
Okay.
Yeah.
This is exactly what my colleague did. That night it was very busy in the intensive care unit in the cardiology division, so the patient was sent, and this is very unusual but sometimes happens, to the general intensive care, where the patient had some chest pain. Remember that he has been defibrillated, he had chest compression, but he also had some VT and 1 VF, so he got a DC shock. So the anesthesiologist got a little bit nervous, and early in the morning he insisted, despite this nice ECG, to have a check. And so we put the patient again on the table, and this is what we see early in the morning. So my question to you is the same. Probably looks a little bit different, I don't know. I mean, the quality of the image is not easy in a webinar, but I will make it for you, I prepare this. So this is as it was at 2 o'clock in the night. This is the ACG, and this is how it is at 8 in the morning with the same ACG. So, Bruno, again, would you put a stent, or you think after 6 hours of stability, this lesion is reliable?
So what we see is indeed a little bit more haziness compared to the last angiogram at night. However, the flow is still good. There is no ECG changes. Another question is the patient under catecholamines? Because sometimes you have some vasoconstriction, if it's not the case anymore.
No need for support.
Yeah, but as long as the flow is good, I personally...
So you remain on your decision.
Yeah, yeah.
You too?
Yeah, I have some hesitation because looks like there's some thrombotic materials in the... because it's hazy on angiography, yeah. So I would may tend to stent at this moment. Yeah.
So at this point, you would have changed your mind and put a stent?
Yes.
And Fahim, you said already that you would have stented this lesion, so you remain on that opinion, or after this second
I do, but to be very honest, with that thrombotic stuff going on, I would be also very concerned that if I stent now, I actually could make things a hell of a lot worse. So I would be in 2 minds. I think with the cardiac arrest happening, I would lean towards stenting it. So what my original thoughts were, but I would be much more worried now, because I'm concerned that once you put a stent, you may actually make things worse.
So this is very real life, guys. I mean, you have super experts, and we don't find an agreement. And even you, I mean, you, Bruno, you maintain your opinion, you change your mind. Also, Fahim, what did we do? I mean, well, probably it seems that the safest thing seems to be putting a stent, although we don't have any proof of that. So this is what my colleague did. He implanted a 3.5 33 millimeters long stent, post-dilated, no problem with the flow. There is no known reflow after the dilatation. And now the question is, does it look better? Of course it looks better. Now it's not stent-like, it's stented PCI. The flow is the same. I mean, there is no change in the electrocardiogram. But of course, the image looks better. Probably the diagonal has suffered a little bit. But there might be a little lesion on the ostium of the circlet. I don't know why it was not moving. So the colleague decided to perform a culotte. And you see what happens. I mean, putting a second stent occluded totally the left main with the hemodynamic compromission. And so this is one of the first teaching we shared with our young colleagues. The best is the enemy of good. This is a very old sentence that is often quoted. But then with experience, with a little bit of good luck, with several dilatations and with tirofiban, We recovered normal flow in the two vessels. You see the patient got an ERBP in the meantime, and the final result looks very good. The ECG remains the same. The patient had no further consequences and was discharged with a relatively good 40% ejection fraction. And as you can see in the ECG, a well-preserved, apparently preserved vectors in the anterior wall. So I know this is very provocative, but I want to know your opinion. You know, there is a lot of people listening to you, so you have a big responsibility. You should say sincerely what you think of this case. Bruno, you first.
So I think the important point came from Farim. It is in such a pro-thrombotic situation, the anticoagulation therapy is much more helpful to the patient than putting a new implant in this situation where you have a very high risk of thrombus.
Mm-hmm. Yoshi, your conclusion on this case?
Yeah, I think it was a very challenging case, and because of the fact that the patient was putting back to the cath lab a second time. Personally, my concern is a thrombus, because as mentioned by Bruno, also the presence of a thrombus might influence the efficacy of the drug-coated balloon. But yeah, as you see that if you do too much stenting, of course, also not good. So I think it is really the provocative case, and so I think the thrombus and ACS in the DCB, I think we need to have a little bit more data to see, and we have to learn more about that. Yeah.
Fahim, your thoughts on this case?
No, it's a great case, and it just tells you that there's so many different ways to skin a cat. I think that one important take home from this is that when you have a thrombotic milieu, putting in a second stent at a bifurcation is something that you should be very careful about, and that's a good time to just balloon DCB and get out. You can always come back and do something extra to the circumflex later.
This is very wise teaching. For sure, we should avoid, in general, using two stents in acute myocardial infarction. This is a very clear message. In this case, of course, when you want to do a perfect job, you risk to spoil it. The question remains whether the first initial result was a safe and a good one. Of course, we don't have an answer because the patient got a stent, so we will never know. But there is growing evidence that the ST elevation infarction might be a good indication for avoiding the caging. Would you comment on that, Bruno?
Yeah, one of the things we have to be aware of that in acute situation, you have a large amount of endogene catecholamines. This means some kind of vasospasm you see. This means you underestimate the real vessel size and implant too small stents typically. And I think that's exactly the case for DCB treatment. Get rid of the thrombus and then deliver the drug. And then the vessel is free for vasomotion in the future and can adapt to its natural size if the patient is out of the acute situation.
Yeah, there are many comments coming on the iPad after this case, and I would say that most of our colleagues believe that DCB in acute coronary syndromes is good. They say leave it, DCB only. Do not add more stents. This complicates acute coronary syndromes. So could the dissection be left even if there is a thrombus in the acute coronary syndromes? The thrombus will not heal or improve because you put a stent. It may become even worse. What the thrombus needs, it's aggressive medical therapy. And so probably in this case, tirofiban made a difference. It's accelerated the dissolution of the thrombus. And of course, you have to monitor very carefully your ICT and give more heparin. Well, we know that. This is a daily practice. So I'm happy that we had the time to show this case and go to the final conclusions. The final conclusions is when you are performing a PCI, generally remember that the best is the enemy of good. This is one of the first things that one of my mentors taught me when I started this job. Stents are needed when the vessel is occluded, no doubt. And if the residual stenosis, after all what we have been saying, the scoring, the long inflations, remains still very tight. We need to send the patient with a minimal residual stenosis, otherwise we need a stent. Dissections sometimes look ugly, but remember, they are still open vessels. And if the patient is doing good, this is very much useful and benign that putting a stent which is occluded, which is an occluded vessel. And this is a worse problem even to solve, because you can reopen a vessel and put a stent, but when the stent is occluded, there are very few remaining weapons to cope with that problem. In acute coronary syndrome cases, complex stenting might be a problem and may cause more occlusions than a balloon-based PCI. Do you agree with that, Bruno?
Of course, yes.
Okay. And of course, at long term, a stented artery never grows. We have learned that, especially in small vessels, stented should be limited to the minimum and the essential. While DCB-based PCI have shown very clearly, and we have gone through that in detail during this webinar, produces vessel enlargement, positive remodeling, and this is very good, especially in small vessels and long and diffuse disease. Well, we have reached the end of our meeting just on time. I hope that you enjoyed it. We tried to make it as practical as possible, and I underline once more, this is based on the experience of experts. It's not supported by evidence so far. Evidence is growing since this technology is driving more and more attention from the companies, from the researchers, from ourselves, using the technology in more difficult and challenging cases. So with that being said, I thank you guys very much for your contribution, for preparing these very nice slides, and I hope that you have enjoyed our webinar and look forward to meeting you at the next PCR webinar very soon. Goodbye.
Thank you.